Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle.
In the early days, I called some friends in the pharma industry and I said, let's take this an opportunity to start videoing people who are working days and nights to try and come up with a vaccine. Let's make it a heroic story. I was hoping it would be a heroic story. At that point, we didn't know, but let's make it a heroic story about how this, because my sense is that if you did a plot and you said quality of life per $100 spent and reputation would be very high in the value per $100 and very low reputation in that regard. And COVID got them to a worse space than they were. And anyway, I want to say one other thing. So we have bureaucracy, physicians, patients. Imagine that physicians also thought about their role as thinking about the long-term trust of the patient in the healthcare system. Then they might want to say, let me spend 2 more minutes on this guy.
Mm-hmm.
Or let me spend 5 more minutes on this guy. It's not for now. It's not for my particular ENT interaction. It's going to be important later for maybe if they get cancer. But the moment we take judgment out of the equation, all of these opportunities for value go away.
It's so fascinating. I took on this new role as assistant dean for faculty coaching. One of the things that I'm doing is teaching a class on psychological safety and trust as a way to bring more organizational trust within our university. You work through this, at least in my mind, that scarcity is actually related to this because the poverty aspect of scarcity, which if I'm understanding is one aspect of the scarcity, is we just don't have the resources. We've got to figure out a way to make this work, and that's going to take some rules, and that's going to create some bureaucracy, and that's okay. We've got scarcity as a reality of the world. But the other definition of scarcity that you're talking about is scarcity of understanding. What's truly real is not well understood. And then when that is present, in an effort to manage that, we can create arbitrary rules. We can do things that, and I'm curious your reaction to this, whether it's at the patient level, physician level, or the bureaucratic level, in an effort to deal with that lack of understanding. There's also, at least in my mind, this idea that you're trying to manage the uncertainty of it. And as a former student of economics, but as a former economics major, decisions under uncertainty was really the foundation around not only economics, but truly behavioral economics, and the work that you've done, and Danny Kahneman and Amos Tversky, and that whole field is really around this idea that when you're faced with this uncertainty, decisions can go vastly awry because you have to fill in the facts, right? And my sense in reading Misbelief was there was a strong thread of that in this, because it's not just the uncertainty, it's the fact that we don't really understand what's happening. That's frightening.
Yeah. Let's talk about psychological safety as a way to think about this.
Mm-hmm.
The classic experiment on learned helplessness, 2 dogs getting electrical shocks. The first dog has a way to move their body and turn off the electrical shock. The second dog gets the exact same electrical shock as the first dog. They come up in the same time, they turn off at the same time, but this dog has the ability to turn them off, this dog doesn't. Then you move the 2 dogs to a new environment. They can learn how to escape a very different kind of a shock. The dog that had control travels, tries different things, figures it out. The second dog lays whimpering on the floor. He basically is helpless. There's nothing I can do. I'm just going to try and move as little as possible to reduce the amount of shock, but I can't. They don't think they can understand the world. And it's very important to understand these 2 different kinds of electrical shocks. So these 2 different kinds of negative consequences. It's very different if your company went bankrupt. Okay.
Mm-hmm.
If you're the only one that was laid off, really tough. It's okay to understand if lots of things, but when something we don't understand, it's very tough. So, we said that bureaucracy basically tells us that they don't trust us, they don't appreciate our time, they don't want us to do anything different, even if it's for the best of our patients. But when we don't understand the reasons, it's much, much tougher. And can I give a crazy metaphor?
Sure, go for it.
So I'm going to say something that I'm not sure if it's true, but I'm just going to give the difference between PTSD and moral injury. Okay, so PTSD,
Yeah, I mean, I know the terms, but yeah, go ahead.
PTSD, I'm in a difficult corner, shooting in me, my body is in stress, and it's correct to everybody, and then I don't get out of that stress. So I have a trauma, it's inside, I spend energy suppressing it, all kinds of bad things happen. It's a terrible disease. Moral injury is when people are forced to do the wrong thing against their conscience. So imagine I'm a soldier and I'm supposed to go at night somewhere and take a kid out of home to convince their parents to give up information or something. I'm just making it. Moral injury, people are not under threat. They are the ones who are the agents of bad activity.
Right.
And the symptoms of PTSD and moral injury are similar. People have things like ADHD, they have problem with authority, they don't sleep, they sometimes have violence tendencies as a consequence of that. By the way, violence tendencies is one of the cases where men go to get diagnosed. They say, where did I get this? And that get them to do this, even though they have lots of other symptoms.
Right.
Now, I think that physicians in the US are under conditions of moral injury. On one hand, people are trained and are taught that their goal. Think about a moral injury is a conflict. You're supposed to do what's right, and you end up not doing what's right. Now,
Right.
I'm not saying all physicians should start being treated with psilocybin and MDMA, but we are understanding more and more about how difficult those things are. We've seen American soldiers that were in traumatic cases of moral injury 50 years ago, and one case has stayed with them for a long time. What happens to physicians who have a clear moral obligation in one direction, and the system is not letting them do that? What a tough situation. Now, imagine that the system basically said, there's a mental cost on physicians. Okay, so this medication cost me $1 more, and this cost me $1 less, and I prefer that you do the $1 less than $1 more. What about the mental cost of the physician? What about their mental health? Right? What if you understood that dilemmas are not things that physicians should be facing? Physicians should not go home saying, today I was not allowed to do what I thought was the right thing for a patient. You're basically diminishing the mental health of physicians by getting them exposed to those cases, I think.
It's a great point. And I think the argument is used often as, again, a battle cry against the administrative bloat, is that you're forcing me into decisions that I would otherwise not make because I know what's right and I know what I need to do.
But there's an element here, right? It's not just wasting time. It's not just changing the decision. It's basically saying the physician now has a mental burden. One of the toughest studies in my field is a study comparing French parents and American parents who gave birth to a sick child. The question is what to do to try and keep them alive or not. And the American physicians say, it's your choice. Here's some papers. Do what you think is right. And the French physicians tell people what they think they should be doing. And no matter what happens with the decision and no matter what happened with the kid, the French parents are better off. Because the American parents wake up with what we call the burden of choice.
Right.
Did they do the right thing? And because of that, they can't move on to the same degree. And the idea is that being faced in a complex moral dilemma has its own burden. And out of even care for the physicians, the healthcare system should say, no, the physicians are my resources. My biggest asset is human capital. This is it. I want to keep that resource working well. I want people to be healthy. I want them to be well functioning. I want them to be mentally at the top of their game. I need to keep that up. And if it costs me another $100 on medication because they don't have to feel bad about something, that's a good price.
So it's very interesting because as I'm listening to you as a student of economics, I'm also remembering the studies that came out of health economics, even as early as the late 70s and 80s, especially when the Rand Corporation did their study on copays in terms of choice. And for their listeners, essentially, that it was a somewhat monumental kind of study that said in the American healthcare system, you can essentially alter people's choices about how much healthcare they consume by introducing the idea of this copay. And that's where we get a lot of this, is this idea that if you tie a financial incentive to how much healthcare you consume, you'll consume less. Is this idea that we're also incentivizing physicians to make quote unquote good choices, because if left to their own devices, physicians are going to be more entrepreneurial and choose things that benefit their pocketbook. And so there are these narratives out there. And this is why I want to bring this up, is because when the system is so complex and people feel like they don't understand yet, and I appreciate the comment about the study between French parents and American parents. Within the United States, we do have a very strong cultural tradition of individual choice, right? And it's why economics has been such a force in the healthcare system, is to say, we're going to give people as much choice, but then we're also going to create a bureaucracy that says you don't actually have a choice. And we're going to create a system where the physicians who, if left to their own devices, we hope for the ideal of making the best scientifically rigorous choices that benefit patients. But we're also laying on top of this story that physicians are burdening the healthcare system by increasing costs because that just benefits their pocketbook. And so for a lot of physicians, I think they're caught in that dissonance. Does that resonate?
Yeah. So look, we can change people's choices with money. No question.
Right. Right.
Actually, I proposed an experiment to the Duke health system. I proposed that we run a running bill on the patient's TV monitors. And they see at each point how much is their bill.
Mm-hmm.
And then I wanted to see whether they'll eat fewer lunches and take less painkillers and get released a day earlier. And anyway, they thought I was evil for proposing it. But of course, in practical terms, it's very hard because nobody knows what the real cost is until
Of course.
afterwards. There are things to do with money. But for example, in the UK, they did a different study where they basically took physicians and they told them at what percentage of prescribing antibiotics they were. You're the top 2%. And guess what? That social comparison was really good. That people to realize where they are. So I'm not saying that financial incentives don't work, but they're certainly not the only thing that work, and they have all kinds of other consequences. Look, if I don't know the healthcare system, but it looks to me that the Mayo Clinic is probably one of the best places to practice and be a patient, and they don't have the same charge per fee mentality. I don't know much about Kaiser Permanente, but I also heard good things about them. But Mayo Clinic, I visited a few times, so I know a bit more about them. Mm-hmm. I can take people and I can make them worried only about money. And not because they are money hungry, because I make it as a measurement of their success. When I was teaching at MIT, we had to teach 112 units a year. And like MIT, there was an equation. How many students, how many hours? I'm good at figure out the equation. I'm also a good teacher. So I taught one class in a year. And I could get lots of students and lots of points, and I would make all my points very easily.
Right.
In fact, I left MIT with lots of extra points in my bank. This was not good for me. It wasn't good for the students. It wasn't good for MIT. But I optimized that. So you gave me a challenge, I optimized it. I think we can be happy in lots of systems that don't maximize our well-being. If you wanted to have a serious look at how physicians are being paid and how they think about their role and other people's role and so on, I assure you we can come up with much better ways to think about money and compensation that would get people to be happier and more productive, right? This idea that you start rewarding people based on micro task is just counter to the human spirit in almost everything we do, especially in medicine.
And it probably promotes a scarcity mindset, if I think about it, because if you end up following each token or each unit, right? The loss of, and this is, I've taken this from behavioral economics, right? This idea that losing $20 feels much worse in comparison to gaining $20, right? In terms of the gain is,
You're behind this year compared to last.
and so it's effective at motivating more work, maybe.
Not necessarily the right one. Yeah, more work
Yeah,
for the
right.
kind that you can get paid for, and it's probably how people evaluate themselves and how they looked at their evaluated by other people. There is this phrase: "You are what you measure."
Yeah.
And if you measure money, you'll get people to focus on money. And if we know with the opioid epidemic, we started measuring pain. People started caring about pain. What do we want to measure? I personally, when I think about teaching, I'll say it quietly so my students don't hear. I don't care about teaching evaluations. And the reason I don't care about teaching evaluations is I would have loved to have the evaluations 5 and 10 years after the class.
Yes.
I want to know. I got a call from a guy. I got a couple of calls from people years later. One guy in particular said, I took your class. I had a problem with my company. I remembered something you taught me. We IPO'd today. I want to say thank you. That's the call. At the moment, he had no concept of what exact piece of information would be useful. Now, physicians, you're in a much luckier territory. There are some immediate effects, but not that many. A lot of the effects take a long time.
Yeah, absolutely.
And it's not about what procedures we do. It's whether the procedure and the human being in the long term do better. So I think like our whole system, we are measuring the wrong things. Anyway, that's a lot of other things. So
we could go on for hours.
let me summarize. I think the issue is that people who are not in the bureaucratic part of the organization feel that they are fighting internally. And when you have an enemy, it's one thing. I'm in Israel right now, Hezbollah, not too far, up here north. Thankfully, there's a ceasefire now. Hezbollah is a real enemy. The bureaucrats in my organization, why are they fighting me? What is going on? It's a very different sense where you say the things are. And it's not only that. I'll give you another sad metaphor. During COVID, there was a huge increase in domestic violence, mostly toward kids. So I started studying a little bit about domestic violence. I had a program that tried to reduce that. And one of the things that I learned about domestic violence toward kids is that it's not so much the physical violence, it's the fact that it's the person that the kid trusts the most. The same amount of physical violence could come from a buddy at their age, very different magnitude, that the person you depend on the most is violent to you.
Right.
And I think when you working at a hospital, the bureaucrats are like your parents.
Correct.
You depend on them.
Yeah. Right.
And the fact that they fight you, it's not physical violence. And so
of course.
it's basically saying, this is not declarative, my enemy. This is the people that I should depend the most on.
Right.
These are the people that should be on my side, on my corner, and they're working against me in this unexplained way. So how do we deal with it? How do we get the mental capacity to deal with it? Very tough. And I think what most people do is they just give up. And they do less, and they don't run into corners, and they succumb. But it has cost as well. It has cost on,
of course,
capacity and motivation and contribution to work.
Yeah.
And it's a shame. We're not maximizing human spirit this way.
Consistently think about ways to inspire, maybe, people to be at their cognitive best. It's, as you say, it's the power of the human spirit, right? Is that we have this brilliant mind and we can use it for all of the good things that have happened through history, right? Amazing things that we've come up with, computers in our pockets, all of these different things. Yet sometimes we limit ourselves through these systems that, again, maybe not intended to be evil in a sense, right? These are not enemies, as you say, but we put ourselves in situations where we're not working together at our best. And I agree, there is.
Let me say, pre-COVID, my office was with all kinds of bureaucrats, HR and so on. And sometimes we had parties and they would come, or if we had issue, we would go to their office. And in COVID, everybody went home. And then post-COVID, they did not return to work. They're working from their home. And everything has moved online and everything became forms. And the thing that I could do by walking to somebody's office and say, hey, this student has a visa problem, what can we do? Has been eliminated. Now, it's all kind of forms in the spirit of bureaucracy are for the average. And if something doesn't fit, there's not a really easy way to do that. And I think what we need to do is to understand that we have these two sub-organizations and we need to mix them. I think maybe do a program was to adopt a bureaucrat where once on Fridays they would come and they would meet patients and they would see what the real work is about.
And vice versa. We don't need to diminish what our friends in the bureaucracy do either, because they're doing important things.
I don't want to diminish, but I also don't agree. The goal of the hospital is the patients.
I agree. Thank you so much, Professor Ariely. This is a real treat for me, and I hope for our listeners. And I hope we can do it again sometime soon.
It will be a pleasure. Next time we'll talk about other topics. One of the things that I'm most interested in these days is how to take the last chapter of people's lives from the time that they get diagnosed with terminal illness until the end of life and make it better. So maybe that will be
wonderful. Absolutely. Thank you again.
Take care.
Thanks for listening. So please share it or like it or comment on a social media post or write us a 5-star review. Thank us again for listening to The Physician's Guide to Doctoring.